Welcome to the virtual trauma meeting. The aim is to provide a friendly environment for open case-based discussions with the help of orthopaedic trainees and consultants to build upon orthopaedic knowledge and experience for undergraduates. Please could you present the case for us?
The patient is a 31-year-old who's fractured his right ankle. He was intoxicated, missed the bottom step and suffered a twisting injury and was unable to weight bear afterwards. He's got a background of anxiety and depression, but he's on no regular medications. He works in finance and smokes 20 cigarettes a day and is otherwise fit and well. On arrival to the emergency department, the skin was healthy. It was a closed injury, neurovascularly intact, and it was placed into a below-knee back slab.
Have you got any concerns about this injury?
Other injuries, patient's intoxicated, fallen down just one step, but definitely could have a head injury. Skin is the main thing. If you have a fracture dislocation, it can become an open injury. And then neurovascular status, check the pulses, check the nerves. So I have a look at the foot, make sure it's pink, well perfused, make sure it's not pale and cold. Feel for the dorsalis pedis pulse. If you get the patient to extend their big toe, you can feel just lateral to that tendon, midway up the foot. So you usually get a dorsalis pedis pulse, and then behind the medial malleolus for the posterior tibial pulse. And then I check the motor function. They're probably not going to have as much range of motion, if any at all, and it's going to be very painful. So I usually, for the ankles, get them to wiggle their toe. On the medial border of the big toe, that's the saphenous. Then you've got the deep perineal, which is the first web space. Then you've got the superficial perineal, which is the top of the foot. And then you've got the sural, which is the lateral border of the foot. I get some pain relief on board straight away. So you use the analgesic ladder, IV morphine if they're in a lot of pain. If a bit less, then you could give codeine or tramadol. But realistically, almost all of these patients, if it's a fracture dislocation, will have IV morphine. So I'd get that on board as soon as possible so that has some time to take effect. In the meantime, what will give the pain relief is to splint this. So put it in a back slab. With this pattern of injury, it's not dislocated, so there's no need for a manipulation. So there's no need to give sedation. You can give some strong pain relief and then place them in a back slab with the foot in a neutral position and then get x-rays of the new cast. We want to make sure that we haven't made things worse. If we do decide to treat this injury without an operation, then we want to see what the current position is. And potentially, if you are putting plaster on, it might be worse. And then what you don't want is to see them in 2 weeks' time and it's been shifted and in a bad position for 2 weeks. So if there's a fracture dislocation, it is an orthopaedic emergency. If the skin is threatened when the patient comes into the department, so if it looks dusky or it's clearly tented, then actually the best practice is to reduce the ankle before you even get an x-ray. Because what you don't want is for the patient to sit there, wait for x-ray, go to x-ray, wait for the porter to collect them, and then an hour's passed and actually the bone's gone through the skin. So if it's clearly deformed and dislocated, you would immediately sedate them and reduce it.
If you were an F1 in ED and this was a patient you were seeing, would you be the one doing the reduction or would you call for an orthopaedic opinion?
Yeah, very good question.
You wouldn't be expected to do it by yourself. If you knew how to do it and you'd done it before, you could say, I've done this before, I know how to do it, I'm confident doing it. Probably the first time do it under the supervision of the senior registrar, but no, you wouldn't just be left to sort this out by yourself.
Okay, good, thanks.
My concern is always whether this is a stable or an unstable pattern. This is a Weber B, so this is where the fracture exits at the level of the syndesmosis. Sometimes this is unstable, and what you can get is the talus, which is the bone at the bottom, the keystone of the mortise, can shift laterally and outwards because that bone is broken, which is holding it in place. Sometimes you can see that on the plain films. Sometimes you need other films to stress the ligaments to see whether it's stable. Weber A is below the level of the syndesmosis. Weber B is at the level. C is above that. A means it's a stable pattern of injury. B means it may or may not be stable. and C is usually unstable. So it's a good classification system because Weber A's you can leave alone. Weber B's you may or may not need to operate, and Weber C's you usually need to operate.
Weber originally described as it comes out of the joint line. So that's why B is a much smaller area. Okay, so that was really nice, John. Thank you very much. Essentially, A's we don't worry about. Anyone who's broken below the level of the joint, they can go into a boot, similar to an ankle sprain. They don't need surgical intervention. They need a boot for some support, and they essentially limit the ankle from going into plantar flexion. You keep the ankle at 90 degrees, which is where we want it to be to heal, to allow all the tendons and ligaments to be in symmetry. So if your toes are pointed, then the ligaments on one side will be stretched and your Achilles tendon, for example, will be shortened. And if you are like that for a long period of time, that's a big problem. That is a much harder thing to deal with than actually just having a broken bone, in fact. So it's very important that we get the joint in the right position in terms of helping with your rehabilitation and return to function. So that's the Weber A's. The Weber A's is essentially treated similar to an ankle sprain. The B's and C's are the areas where you get more interested about stability of the ankle joint. John talked about the mortise. If you can all just Google on your phones what a mortise lock looks like, and then imagine that the talus is part of that. The part of the fibula here and the tibia here form a bit of the door that the lock goes into. It gets more complicated than that, but I think for the time being, we'll just sit with that. It's one block that goes inside a groove.
Does anyone want to have a go at describing this fracture?
Is a Weber C fracture.
All right, very good.
What makes you say that?
Because it is above the syndesmosis.
Perfect.
Absolutely, well done.
What do you think about the lateral X-ray?
There's two things that you could comment on.
Is it slightly displaced or dislocated?
Yes, both. Absolutely right. So on the front, you've got this line that comes down here. It's very smooth all the way to the end. But at the back, it's not. It gets to there and then something happens. So there's a fracture at the back as well, isn't there? Excellent. And that's why it's moved in that direction, because it hasn't got that support at the back. Because tendo Achilles, which comes down there, is actually pulling that up. It hasn't got that bony support at the back. And he's got a posterior malleolus fracture. Lateral malleolus, medial malleolus, posterior malleolus.
If you're examining an ankle joint, you'd feel a medial and a lateral malleolus. Can you feel a posterior malleolus?
No. With a Weber C, you're suspicious of it. And so sometimes you need to get a CT scan to see it better. That's not necessarily something that you would do as the emergency department doctor, but it's something that if you were the admitting orthopedic team that you might organise. It doesn't need to be done immediately. The immediate thing is the reduction of this, putting the bones and the joint back in the correct place. That's all reduction means. And it's only reduced once it's back in the right position. You can manipulate it, but you can manipulate it into a wrong position or manipulate it and only move it a little bit until it's reduced. Reduced means back in an anatomical position, in the correct anatomical position.
The principle about reducing any fracture is to reverse the injury. So you can see that this ankle on the lateral is trying to slip out the back. So the best thing for ankles is you start off with some sort of sedation. If they're quite tough, you can sometimes get away with Entonox and some IV morphine. Otherwise, usually you get the ED doctors to give something a bit stronger. You'll be at the foot. You'll need someone to hold the thigh, or you can use a triangle under the knee to bend the knee. You then need another person, ideally, to do the plastering itself. So when the patient's asleep, nice and relaxed, all the muscles are loose, you pick up the foot by the toes, or even just by the big toe, and often you'll then hear a clunk as the weight of the leg actually pulls the tibia backwards relative to the foot, because you're holding up the foot and the weight of the leg is pulling it back. So that will usually reduce most ankle fractures. sometimes you do need to do some gentle traction as well. And then once you feel that it's in, I usually put the foot on my chest or stomach, and then you wrap it up with wool, and then you put the back slab on, which is a big U down both sides, and then a nice big one down the back. When ankles are dislocated, they almost always go outwards. So you give them sedation. Rather than picking it up by the toes, what you might want to do is start off with some traction because of all the muscles pulling it up. So gentle traction, which brings it out to length, and then you'll feel a clunk. Then you can hold it by the toes, which maintains reduction. Put the foot on your chest or belly, and then use both your hands to mold the cast as it sets.
What I've tried to show with the arrows is in a two-dimensional image what is actually your three-dimensional force. Arrow number 1 is pushing the tibia in that direction, and arrow number 2 is pushing it back and across. Okay, that is going to be your reduction maneuver. So that is, if this is a right ankle, that's going to be your right hand, which is on top of the front of the tibia. And that's how you're going to reduce it, and that's how you're going to hold it, and that's how you're going to mold it. Your left hand is going to be cupping the heel, and that's going to be pulling it forward where arrow number 4 is, and pushing it laterally where arrow number 3 is.
One of the unfortunate myths about orthopedics is that you've got to be a very strong individual to do it. And I just think that is incorrect. And I think if you understand the techniques, the force becomes much, much less.
As a take-home message for any reduction, I would say is, for us, it's the technique rather than the force. It is definitely the technique. But more importantly, I'd say, is the sedation, because unless a patient is appropriately sedated, their leg muscles are stronger than your arm muscles and anybody's arm muscles, and you will not be able to reduce it if they're fighting you.
Thank you for listening. We hope this has been informative. If you have any questions or suggestions for further programmes, please contact us at the Grand Academy at btinternet.com.